This is the first in a series of Grand Rounds style webinars that the MSGERC, together with Terranova, Medica, is helping to put together. Today's topic is going to be challenges in invasive candidiasis, and we're going to employ sort of a case-based approach to this seminar, and we will go back and forth with commentary, and then we will open it up to those of you and the participants to ask questions, pose questions, make comments, etc. We want this to be very user-friendly, and we will encourage as much participation as is possible. I'll introduce myself. My name is Peter Pappas, and I'm at the University of Alabama in Birmingham, and in charge of the scientific committee of the MSGERC. Our other presenter today, and the main presenter of the cases, is Brenda Tesini. She's a physician and assistant professor in medicine and pediatrics, has a joint appointment, and she's at the University of Rochester in New York. Again, to ask questions or to make a comment, use the chat box or raise your hand. And then after the initial presentation and then our initial discussion, we will turn off the slides, and then we will get to the questions and try to get to as many as we can in the time allotted. And I want to emphasize that this is being funded through a cooperative agreement through the CDC and CDC, and it's a grant that was awarded to UAB, being administered through us, but our educational partner is Terranova Medica, and they've helped to develop this program and some of the content contained therein. So with that brief introduction, I want to get right into the cases and introduce Brenda Tesini, who's going to present cases 1. We'll have a discussion, and then we'll stop, ask for questions, and then we'll get into case 2 in the second half of this presentation. Okay. So Brenda, if you want to get started, I'll just advance the few slides that we have. We're going to use these slides really to just kind of facilitate discussion and make bullet points.
Great, thanks a lot, Pete, and welcome everyone. The first case that we have here is a 63-year-old gentleman with really limited medical history, hadn't been seeking a lot of medical care over the past few years until he came down with COVID. Like many patients these days, and was seen in the hospital, just spent a couple days there, got some antiviral monoclonal therapy for that acute illness, and was found to have a demand-mediated non-ST elevation myocardial infarction at that time, managed medically, set up with cardiology follow-up for that. And actually on the way back from his follow-up appointment, had a cardiac arrest in the medical transport vehicle, actually. So he was attended on the scene, got several rounds of resuscitation, and was found to now have an ST elevation MI, went straight into the cath lab for intervention with a couple stents placed. And that landed him in the cardiac ICU in multi-organ failure. He had respiratory failure, so intubated, signs of acute kidney injury, had a rather prolonged change to his mental status. He was treated for presumed aspiration pneumonia with pip/tazo, also received some dexamethasone, both for his acute illness, and also concern that maybe some of his respiratory disease was part of his COVID illness as well, with that timing kind of fitting there. And while he's receiving these treatments, so about 5 days into his hospitalization now, is still having fevers, after he had been on the cooling protocol for the first few days. And what they felt was a persistent leukocytosis, despite their current interventions. So, as one does, working up and looking for signs of additional infection. At the time, no focal exam findings. He was still intubated, hard to really get much out of him in terms of symptoms. He had 3 sets of blood cultures drawn, peripheral, one from his central venous line, which is the IJ line, and one from a radial arterial line that he had in at the time. And all of these cultures did eventually grow out Candida glabrata. Took some time. We'll go through the micro in a little more detail later. And the approach to this case at the time was he was started on caspofungin after the blood cultures turned positive. He had just remained on the pip-tazo that he was already on while the team was waiting for those culture results. And all of his lines at the time, the only devices that he had in place was the central venous line, the arterial catheter, and the only other foreign material he had were those 2 new cardiac stents, but otherwise no other prosthetic material or devices. He had repeat blood cultures taken, which corresponded to about 2 days after the initial cultures, which was when those turned positive, and those were negative. So I think we can go to the next slide and get a little more objective data at the time. So this was the leukocytosis that they noted. He had a few bands. Otherwise at this time, he still had, for him, this was acute kidney injury with elevated creatinine, and some signs of liver injury as well. The really main imaging obtained at the time was this chest x-ray showing some of those ongoing concerns in his lungs. He was also getting some focused echoes throughout this time to assess his left ventricular function in the context of his MI, with really no valvular comments. And that was really kind of the extent of the workup. And I think some discussion points we might have about this case is that adequate? Are there other things we should be thinking about? You can go ahead to the next slide just to, I'll be on the same page with microbiology data that we had. So upon admission, he still had his positive SARS-CoV-2 PCR, did get ultimately 3 sets of blood cultures, right at the time and shortly after his admission that were negative. Had some tracheal aspirates taken both at admission and throughout his hospital stay that would keep demonstrating what was reported out as normal throat flora. And then this was in hospital day 6, actually, when these all 3 sets of blood cultures grew the Candida glabrata. And to note, the laboratory did report out time to positivity on the automated system, 40 hours from the arterial catheter, and closer to 80 hours, both from the central venous catheter and a peripherally obtained culture. And again, about 48 hours, multiple sets of blood cultures were negative, and that corresponded to probably having had about a 1 dose in of therapy. And antifungal susceptibility testing was performed on one of those isolates that showed to be sensitive to caspofungin and in the susceptible dose dependent to fluconazole. And so with this information, the patient did stay on caspofungin for 2 weeks of therapy from the the time, I think it was maybe even a little bit before they had documented negative cultures, but essentially 2 weeks of therapy from the time of negative cultures. And follow-up is he was discharged around that time and has not had any further sequelae as far as we know through the medical record. No official infectious disease follow-up for him, though. All right, and we can go on to hear some discussion topics that have come up, certainly for me, when thinking about this case. And I think about this case as, kind of a little more of a straightforward invasive candidiasis with candidemia and no clearly identified deep-seated source. And my thoughts are kind of, could we have done more? Could we have done less with this case? Did he need to stay on an echinocandin for the duration of his therapy? Was this arterial catheter truly the source of infection? Specifically, should there have been a more formal ophthalmologic exam, particularly in a patient who was stated intubated at the time of his candidemia? And how do we feel about the duration of therapy?
Okay. Right. Brenda, thank you. I guess I would characterize this as a kind of a bread and butter case, one that occurs all too often. And just a couple of comments, observations, and then let's maybe go through some of these questions or bullet points, and then we can address some of the questions. Dr. Chandrasekhar, before I get started, was asking a question about, was a beta-D-glucan obtained during the workup prior to his candidemia? I'm guessing no, but I don't have I don't know the answer to that. Do you guys routinely do beta-D-glucans on your subjects?
We do not routinely, no. So one was not obtained. It has become slightly more common in patients with COVID. And so I thought this was also another aspect of this case was the COVID association. So I'd say they've become a little more common, but not very routinely done. And I think, I know at least at our institution, when we get the consult question to interpret a positive beta-D-glucan test, that's often met with a sigh.
Yes, a sigh of frustration sometimes.
Yes.
Well, I mean, let's talk about the context of the case. First of all, I think that one of the points that you make here is the association or possible association between COVID and invasive Candida infections. And so there has been a lot of attention on mold infections, especially aspergillosis and mucormycosis, in the context or the setting of an active COVID infection or post-COVID in the case of mucor especially. But I think that more and more it's been recognized, and now we're seeing this in published data, that it might be the candidemia especially, but invasive candidiasis as a global more description, but candidemia specifically is really common in these patients. And some of the data coming out suggests that the rates in patients with COVID who are, especially those who are intubated and in the ICU, may be as much as 5 or 10 times the kind of baseline rates of candidemia in those same institutions. That's certainly been the case here. And we're in the midst of gathering data on now in excess of 200 patients in a multi-center trial, where it really does appear that among COVID patients who are on the ventilator for 72 hours at a minimum, that the commonest fungal infection that they experience is not aspergillosis, but rather candidemia. And, the driving forces behind that, the whys and the wherefores, not clear. They have abundant risk factors, as you know. And, this gentleman kind of demonstrates that. Intubation, he's been in intensive care unit, renal dysfunction, lines, antimicrobial therapy, etc. So, you don't need a lot more risk factors in order to say this fellow is high risk for invasive fungal infection. I think the question remains as to whether COVID specifically is an independent predictor of candidemia, and I'm not sure that we know that just yet. The first point that you bring up relates to the echinocandin as initial therapy versus an azole. Probably few would argue in this case that Candida glabrata would, if you knew that that's the organism, and apparently you knew that pretty well, pretty early, that the echinocandin probably makes the most sense. I'd say certainly makes the most sense in this situation, because it is dose-dependent azole susceptible. But what are your thoughts about echinocandin v. azole as primary therapy, let's say in candidemia due to Candida albicans or Candida parasilosis or something like that?
Yeah, I'm still wary of the azole for initial therapy. In most cases of candidemia, generally these patients are just so sick that I will always preferentially go for the echinocandin for initial therapy. And I think certainly in parapsilosis, in our region, through our participation in the CDC's Emerging Infections Program, we know that we have for parapsilosis, about 15% of our isolates are resistant to azoles, and that's initial isolates straight off the bat, often in antifungal naive patients even.
Oh.
So yeah, until I know for sure that it's going to be azole susceptible. We've even had a couple of albicans isolates recently that are azole resistant. So I think for that alone, I would go for the echinocandin, and I like to see a little a good response to the echinocandin.
Evidence of clearing.
Burden down. Yeah, exactly.
Evidence of clearing, right? I think that the data suggests that while the two may be comparable in terms of echinocandins versus azoles in any one study, if you combine them and if you do the combined analyses, it really does appear that the echinocandins seem to be associated with a better outcome, and that's independent of susceptibility data. It probably relates to cytality, perhaps more rapid clearing of the bloodstream. Those are hard to tease out in the context of one, 200 patient study. But if you aggregate these data, I think it really tends to be singled out as an important first line therapy, and I think that's why the echinocandins are favored. And then transition or step down to an azole becomes possible in the right setting. Usually, once you have the susceptibility data available. The question often comes up in this patient, and I'm sure you get asked this as well. Okay, we've got a glabrata that is azole susceptible at a level, an MIC of 16, or maybe even 32. And they might come to you and ask you, gee, is it okay to give this person fluconazole at that time, and at what dose? How do you answer that, Brenda?
Yeah, I really take these patient to patient. I think you have to look at the overall big picture. If it's, I want to see that really strong clinical response already to your echinocandin, and basically don't be asking the azole to do much work for you.
Yeah.
Is how I think about it. And, in an individual patient, if it's going to mean, prolonged IV access they wouldn't otherwise require, home with a PICC line, or prolonged hospitalization to continue to administer the echinocandin. In those situations, risk benefit, if I know that we don't have deep-seated infection, we've cleared, demonstrated clearance of the candidemia, then I might consider an azole, and probably would try and do the higher dose if I was feeling uncertain.
Yeah, I think I think we're all on the same page with that. I want to move on to the next question. The arterial catheter, question mark. Do you think that's the source of infection in this person? This person had central lines at some point, correct? Okay.
Correct, yeah.
What are your thoughts about this?
And my thoughts in general are, I'm very skeptical of the arterial catheter, ever being a source for, a quote unquote line related infection, just with the physiology of where the catheter is, and the pulsatile blood flow kind of directed out of the catheter. But that was the determination made at the time of this. I think the central venous catheter would be a much more likely source. That real differential in time to positivity, I think is what drove my colleagues at the time to implicate the arterial catheter. Yeah. Where I have seen some more clear-cut infections I feel more comfortable associating to the catheter if there's, an obvious issue at the site. And so then it almost becomes more of a, soft tissue infection related to the catheter placement. Yeah. And there wasn't real documentation of this at the time, and I didn't see him until later in the course to kind of know if there was anything at the site that, that site could still have been a potential source, but he had a lot of other things going on. Yeah. So I don't feel quite as comfortable, I think, as the folks making the determination at the time.
Yeah, I think time to culture positivity might be seen as a proxy for organism density, perhaps. Mm-hmm. I don't know that that's necessarily true, and I'm not sure that based on that alone that you could implicate the arterial catheter. I think most of us recognize that arterial catheters compared to venous catheters seem to be much less likely to be infected, but it does occur. It just seems to be more likely. I don't think we're going to solve that based on the information that you presented. I do want to move on to your next couple of questions. One is the ophthalmologic exam, and then I think we can handle the echocardiogram question pretty quickly. But I'll just say personally, we've received just a lot of queries recently about the need for the ophthalmologic exam. Suffice it to say that there are at least two schools of thought at this point. One on the ID side, and especially focusing on the IDSA guidelines published in 2016, that everyone with candidemia deserves an ophthalmologic exam, dilated fundoscopic exam by an experienced clinician. Now, that position is moderated in the ECMID or the European guidelines, where higher risk individuals, those with symptoms, those that are on a ventilator or unconscious, are kind of really highlighted, and all others become something that's driven by clinical need. The American Academy of Ophthalmology has come down on the side of the less aggressive approach, and really at this point kind of limited to symptomatic individuals and people who are unconscious and can't complain. And their rationale is that if you treat these individuals with conventional therapy, that any chorioretinitis that they might have, that you might have seen, goes away with 2 weeks of treatment. Our position is different. Neither position has a ton of data to support it. And so here we are. And I think there are a lot of opinions, again, in between. But real briefly, what are your thoughts about this? What's going on at your institution?
Yeah, we do get some pushback from ophthalmology. I would say, our ID group, by and large, always requests an ophthalmologic exam. We're fortunate to have on-site ophthalmology, and it's a really, certainly minimal risk to the patient. Not a whole lot of time on their part, from my perspective at least. And to me, it seems worth it. The risk benefit calculation of potentially being able to intervene seems worth it. And again, I think that that the likely majority of patients with candidemia, for one reason or another, can't give you great symptoms and history. And I think that's often the counter argument on the ophthalmologist side is to, as you stated, in the absence of specific symptoms or concern. So we are getting some pushback though, and it's surprising me.
I think we all are. I want to go ahead and say, I'll say one word about the echocardiogram. We do not recommend an echocardiogram routinely in these patients. It's not part of any guidelines that I'm aware of. And to extrapolate from what we might do with Staph aureus and apply that to candidemia really is taking a step. I know it's routine at a lot of places. It's not really so much driven by data. But I mean, obviously in circumstances where there's an underlying valvular lesion, prosthetic valve, persistent candidemia not clearing, then those are indications. And as far as duration of therapy, I think most would agree that the 2 weeks is appropriate. Let me turn to the comments and the questions that are in the chat at this point. And so we talked about the BDG. Lewis White in the UK is talking about, mentions that the BDG can be very slow to return to normal. And so it's probably not a good surrogate marker for response to therapy. And we think it's, and I would certainly agree with that's something that we generally don't do. There's a comment about the COVID association of candidemia, and I think that a big part of that, I mean, there may be obviously immunosuppression involved, but very clearly this group of patients has enormous overexposure to antimicrobials, antibacterials, because they all have pneumonia almost by definition. And so empiric antimicrobials are just extraordinarily common and really overused in this population. There's a comment about if anyone has looked at whether non-ophtho performed dilated exam has been studied, and then with escalation ophthalmology if needed, not formally. And I've talked with our colleagues, Neil Clancy and Hung Nguyen at Pittsburgh, and they've highlighted a technology that they mentioned in their recently published CID article that I'm not familiar with, but it's basically where a common user, any internist, could take pictures of the fundus, and then anything that is seen as abnormal could then be referred to an ophthalmologist. There are a lot of problems inherent to the ophthalmologic exam. One of which being, what is the definition? How do you define endophthalmitis, chorioretinitis, there's a lot of misdiagnosis in this setting. There's a question about how long do you give initial antifungal therapy before citing that an organism is not susceptible, and do you change treatments? I think that for many of us, susceptibility is a privilege. I mean, we get it. It's really a benefit. We do them on site, and so you might have your result in 4 to 5 days, and you can make a transition. But what if you are in a setting which represents most settings where maybe you get the species, but you don't get susceptibility data? And in that setting, I think you're really kind of left to make clinical decisions based on clinical response, persistence or clearance of blood cultures or cultures from whatever the source is, presumably the blood, and then the predictable susceptibility. So, for instance, for Candida glabrata, in the absence of susceptibilities, you may not use fluconazole, or may use it very carefully. I want to mention that Neil responded to my question. It's Hong has done 11 patients with a digital camera, and that this is actually something that hopefully could be done and translated and used kind of more globally. It's something that is not generally done at this point, but my goodness, if we can't get ophthalmology on board for whatever reason, it's going to be dependent on us to start generating these data and then providing ophthalmology with more detail. I don't want to spill over into the second half of this and not give the second case the time that it deserves. So I'm going to go ahead and move on to that, and we can move to our next slide. And this is going to be case number 2. And so, Brenda, I'll ask you to this is a complex case, but I'll ask you to kind of briefly go through this. And
yeah, certainly. I can kind of summarize this a little more quickly. If you want to just pull up the next slide, that'll give us the overview here. So MS is a 31-year-old gentleman whose medical history most notable to us for bipolar disorder and injection drug use, for which he's been on buprenorphine for several years, but had found that he gets better control of his cravings when he dissolves it and injects it. And he has had no known prior infections until about a month before his presentation. He did have, what sounds like per description, a boil at an injection site that went away without any particular treatment. But he had several weeks, about 3 or 4 weeks of severe headaches, night sweats, and likely fevers, seen in the ED several times. Blood cultures never taken. At one point, lumbar puncture was recommended, but he chose to leave instead of complete the workup. And he presents now basically collapsing, having several seizures, and right-sided hemipresis, was found to have very large intracranial hemorrhage, with several mycotic aneurysms, and went for urgent craniotomy and clipping of the aneurysms. And, this is all in kind of the first day or so. In workup for that, gets a transthoracic echo, which shows a previously unknown, likely bicuspid aortic valve and what looked like a mass there. 2 sets of blood cultures were taken after his surgery, after his cefazolin antibiotics for the surgery, and he started on vancomycin cefepime. And ID is called probably about hospital day 2 now that he's out of the OR, and kind of the initial thoughts are he probably has a staph endocarditis. And about a couple days go by, no culture growth yet, and wondering if this is an MSSA that was perhaps, cleared enough from the cefazolin when blood cultures were taken. And then lo and behold, his blood cultures do grow Candida parapsilosis. And so now we can go through his quite prolonged hospital stay. We have an inpatient rehab unit. So he kind of went back and forth between the acute hospital and the rehab hospital for a couple months at least. And so we have initial blood cultures. So as soon as those started growing yeast, he started on caspofungin. And probably it took about a week of therapy, and realized that, he started on our classic 70 milligram load, 50 milligram daily caspo, and then was increased to the 150 milligram dose about a week into the hospitalizations as blood cultures continue to remain positive. Even on that, several days into that, he still is having fevers, still will pop positive blood cultures, all for this parapsilosis. And fluconazole ends up getting added, and again, on both the kind of standard and higher doses. Continues to have some complications. He has leukopenia, and by this point has cleared his bloodstream with several cultures. And so team at the time is trying to figure out why he's quite so leukopenic, really quite neutropenic at this point. They're trying to stop all meds they can, hold his caspo for a little while. What do you know? Fevers come back, blood culture is positive again. Fluconazole resistance is now demonstrated, and caspo gets restarted. And by 2 months in, it's decided that this valve needs to come out. They were really hoping to wait, with this large head bleed. He was still having vasospasms, but it was decided that really he needed to go for replacement. And he had a actually fairly smooth course after that for some time. So again, he has over 2 months of intermittently positive blood cultures, no bacterial pathogens ever identified. And these are some of the susceptibility reports we have. So again, about a couple weeks into therapy, resistant to the fluconazole and intermediate to VORI. The tissue was still culture positive, and the isolate from that did seem to retain susceptibility to all of the agents. So he completed 6 weeks of caspofungin from the time of surgery, and did fine for some time. Actually made it home out of rehab, still has right-sided hemipresis, some aphasia. And here are just some of his images. Again, quite a large area of head bleed, a nice large mass there on the valve, much better seen on the transesophageal. And some discussion points, and there are plenty of others as well. And I think there were some discussions already brought up in the chat about, when to consider empiric antifungal. And I was interested in hearing from the group as well about people who inject drugs as an emerging risk factor, particularly for community onset candidemia and a much different patient demographic than we would think of as classic, and go from there.
Well, let me start the discussion by saying that we never gave a heck of a lot of thought to community-acquired candidemia and endocarditis, and fairly recently, the CDC came out with a survey at some of their sentinel centers, and identified that among patients with community-acquired candidemia, almost 20% of them had endocarditis, and most of it was related to injection drug use. So it's an evolving type of phenomena, and not one particular organism involved, although we all know that the parasilosis is perhaps stickier than others. But I mean, this is a relatively new phenomenon. It seems to be following the injection drug pandemic. And so it does beg the question as to who should receive empiric antifungal therapy, who comes in with injection drug use as a risk factor. And unfortunately, for none of the for each of these points, there's not a real answer. So there's a lot of anecdotal data, there is opinion, but I think it's something that a lot of this is really driven by personal experience and kind of what we might call common sense. Although I think we're really lacking anything that resembles a controlled trial of any sort. So I just mentioned that as a starting point, that this is an evolving issue. The thing that I found striking about this case, and I would love to hear comments about this, is the inability to really sterilize this person's blood cultures. And even after 8 weeks of treatment with, I presume, higher dose caspofungin, and even with fluconazole, with the combination, that you're unable to sterilize them either when their valve was in place, and even at the time of resection, the valve was still culture positive. Now, the distinction or the differential between the fluconazole susceptibility that you demonstrate, I don't know what to make of. I don't know what to make of, other than, well, I'm not enough of a expert in antifungal resistance and what sort of milieu is likely to promote or restrict this. It is interesting, though, that on the heart valve, you seem to have the wild type isolate, and from the blood, you seem to have something that has developed resistance while on therapy. So I think it's really, really interesting. Todd McCarty has highlighted some of these papers on injection drug use and the use and the development of Candida endocarditis. I think it's again, I think it really highlights the fact that these are unquestionably something that's really kind of evolving. As far as antifungal dosing and endocarditis, again, most of this is driven by anecdote. Most of us would probably use a higher dose of echinocandin. I think that the question comes up with Candida parasilosis. Well, gee, these are quote unquote relatively resistant to echinocandins because they have higher cutoff values for susceptibility. But there's a lot of data to suggest that one should steer away from the echinocandins unless they're really, frankly, resistant. You can make the case for amphotericin, I think, in these papers. Some people would. Some people, in the face of persistent positivity, would give this person amphotericin plus 5-FC and give the old-fashioned regimen. I've seen individuals use amphotericin plus the echinocandin, so kind of combining two cidal agents, if you will. Does that make sense? Certainly, higher dose and consideration for dual antifungal therapy makes sense. And if anybody deserved a trial of it, it would seem like your patient deserved that trial because they were failing treatment. You agree?
I do, yeah. And I think that's a very interesting discussion point that I've noticed our institution in general, we're just very wary of any of the amphotericin formulations for, poor tolerance and toxicity concerns. But I think he really likely could have benefited from that.
Yeah. There's, I think Lewis White made a comment. Is this what we have on the one hand, refractory disease, an individual who's not clearing with conventional and pretty aggressive therapy. And so they have refractory disease on the one hand. On the other hand, I mean, does this represent, true resistance, especially when you've got disparate results like these? And again, I don't know what to make of these results. You have at least one active agent throughout the treatment. And I mean, from my perspective, I'm more inclined to call this refractory disease rather than, resistance. I think resistance, in my view, suggests that you're failing because the antifungal is not active, whereas with refractory disease, it may be a source control issue. And in this patient, you can make a case for both, but the source control was clearly an issue when you had positive cultures obtained from the resected valve 8 weeks after initiation of therapy. So pretty dramatic. Okay.
Yeah, and his follow-up is that he subsequently, sometime later, this case was, right at the beginning of COVID, I think how we measure all time in the last 2 years. He did represent with a parapsilosis knee septic arthritis after a fall, and it was I wasn't involved in the case, but in looking this back up, I was surprised to see that. And it was determined to be post-traumatic kind of direct inoculation as opposed to hematogenous and concern for now a kind of recrudescence of his.
Did he have Candida parasilosis in the joint?
Yeah.
Well,
yeah. So I think it's a little coincidental.
A little too coincidental for me.
Yes.
Neil Clancy asked the question, and I guess when you read cases like this, you always have to put yourself in the middle and say, what would I have done, or what might I have done? And I guess assuming that he would allow me to with his renal function, one wonders whether a lipid formulation of amphotericin B might have been, one might have gone to that soon, or as soon as it was clear that you weren't on top of the organism and actually clearing it. Given the concerns that we have about the relative resistance of parasilosis to the echinocandin class, the development of azole resistance that you have in hand, and whether transition to amphotericin B would have made some sense. I again, without knowing the answer, it would certainly have been very, very attractive to consider doing that, maybe with the addition of caspofungin and using dual therapy in this patient who clearly failing microbiologically. What are your thoughts?
Yeah, I completely agree, and I'm really not sure why that wasn't pushed a little more. Yeah. He did have some periods of renal dysfunction, and frankly, I think it also speaks to our management of providers switching over, teams switching over, and you have a few good days with negative cultures and you think you've got it now. And it's not until you really step back and look at the big picture that you're like, wow, no, that was about 2 months of really not having control of this infection. And I think it's being brought up in the chat now too. So much of the focus at the time, I recall certainly when I was seeing him was really trying to push the cardiac surgeons to get source control. And I think that's our ID mantra is needing source control. But that, perhaps, we did still have some options that we could have explored a little more.
You can understand while they might have balked at this because they don't want to have fungal prosthetic valve endocarditis, and yet it's a balance. And so clearly the source was an issue. Convincing the cardiac surgeons to do what we think is appropriate, and this is really kind of paramount. Antifungal therapy is important too, but this is really a great example of needing the combined approach of both source control and the right antifungal, and it's hard to know, which of those was more important in this setting. But again, if the cardiac surgeons are not really, enthusiastic about doing a valve resection or replacement, then you might be left with no choice but to go into amphotericin. And again, as I say, in retrospect, it's easy, but I might have gone to that earlier, to be honest.
Yeah.
There are a couple of comments one question that's just informational. How long did he continue antifungal therapy post-op? Was he given 6 weeks, 8 weeks, or
about 8 weeks?
About 8 weeks post-op.
Mm-hmm.
And he had no further positive cultures until his knee popped up at that point.
Correct.
Okay.
Yep.
All right. So I think we're gonna probably wrap this up with the final point that that really relates to a very, very recent article that was just published, and this is the Ambition trial. And you'd say, well, gee, that's something that relates to cryptococcal meningitis. But in the Ambition trial, for those who aren't aware of it, a single dose, 10 milligrams per kilogram of amphotericin lipid, true ambisome, if you will, if we can use the trade name, liposomal amphotericin was given and appeared to be as effective as more conventional therapy. I believe it was 7 days of amphotericin B, and I think it suggested that these individuals sterilized more or less at the same rate, that their outcomes were very similar. And so, especially in a setting where you're resource deprived, giving a single high dose of liposomal amphotericin seems to be an effective alternative to conventional therapy. And so the question is, how can this apply, or does it apply to other conditions? We're dealing with something that, we're talking about a CNS infection, a protected space. But I think the questions being raised is, if this works for a CNS infection, would it be something to consider as an alternative or as a supplement to conventional therapy for, in this case, Candida endocarditis? Once weekly ambisome administered as 10 milligrams per kilogram in an effort to protect, renal function or whatever, and given as adjunctive therapy along with conventional therapy. I mean, this really gets out there as to things that have not been studied, but I think it's worth kind of opining about. Mm-hmm. What are your thoughts about this, Brenda?
Yeah, I think we really need to, especially as invasive candidiasis continues to rise, and our mortality, our complications from it are not going down. So as the burden increases, and as we kind of explore more of these both recalcitrant and resistant cases, I think we need to consider newer options, and especially cases like this highlight that the need for both more timely diagnostics as well as aggressive treatments.
Well, I think that the ambisome option makes some sense. Neil highlights the fact that it's picked up by the RA system. It does hang around for a long time. again, I mean, this is something that just simply would have to be studied in a clinical trial setting, but it really does open up the possibility for using amphotericin in this way as an adjunctive therapy.
Yeah.
Probably not primary, but as potentially adjunctive therapy. So, all right. Did you have any other comments or insights, Brenda, before we bring this program to a close?
I think we're good to wrap up. Thank you.
All right. Well, Brenda, I'd like to thank you so much for putting together these cases and presenting them. I also would like to thank the over 200 people who were signed up for, and hopefully most of them joined us today. And would like to thank you all for being part of this program. If you have comments, questions, we'd like to, Lisa will include these in the chat so that you have a method by which you can get back with us if you have things to say that are positive or negative. I'd like to hear about it. Again, this is the first of several of these programs, and we're going to be conducting these over the next few months, and would encourage you to attend these to the extent that your time allows. And again, I would like to thank Brenda for presenting some really great cases, and Terranova, Lisa Tushla, and Tom Davis for their assistance in putting this together. And then finally, for the CDC, who has provided the funding for this program. And we look forward to doing this again in the very near future. So thank you, everyone. Have a great day, great week. We'll talk soon.
Thanks, everyone.